disclosures. So there was an AUA it wasn't necessarily a town hall meeting, but at the meeting this past year in May, some of the experts who, manage renal cell carcinoma got together and they had a panel discussion about what to do for management of small renal masses. So there was Dr. Uzo, who's the moderator. He's a sort of descendant of Dr. Novick and, a great guy, amazing surgeon. There was a radiologist. There was someone who worked with markers, Dr. Lochschwager. And they got together to discuss what to do with these small renal masses. So again, what do you consider to be a small renal mass? I say a mass under 4 centimeters. So T1N. Risk of Mets. Well, looking at the memorial data, we know that the risk of metastases for small renal masses is relatively low. So how do you stratify care of a patient with small renal masses? So again, PT1, they grow relatively slowly over time. Nephron-sparing approaches are preferred. So again, you're dealing with someone sort of T1. I showed this slide before. The risk of Mets, small renal masses, incredibly low. Not negligible, but low. So measuring biological tumor risk. So with prostate cancer, we have the D'Amico risk criteria. Dr. Hassan spoke about testicular cancer. There are ways in which we stage and grade, testicular cancer. We know to act according to certain pathways because of the pathologist, because of the novel findings. But with kidney cancer, do we have the same thing? Are we doing as good a job with mapping out strategies? Not quite, but we're getting better. So there's a thing to look at. So we have a small renal mass. So there's a function of experience. What's your experience in dealing with small renal masses? Radiology. Is there such thing as a radiographic biopsy? Biopsy. What's the role of biopsy? And markers. Are there serum chloride markers for kidney cancer? We don't have a PSA for kidney cancer yet. I think it's coming, but we don't have it yet. So what do you do? So Dr. Dudawala from USC was the radiology expert who participated in the panel. Jamie Landman was the chair of UC Irvine, spoke about biopsy. And Dr. Lochschwager spoke about biomarkers. So stratifying the care of small renal masses, imaging. So they're doing some pretty cool things at USC. So again, small renal masses, 15 to 25% of them, if you remove them, they're absolutely benign. And predicting biological behavior, calling a mass malignant based on the way it looks, it's just not appropriate. So, what if we could take a lesion and extract quantifiable data of that image and associate image findings with pathology findings? So we can't quite do that yet. So looking at things, there are things that we can look at. We can look at the image signal, the density, the intensity, the echogenicity. Here, this is the lesion. Then we can look at the physical features, the size, the volume, the shape, the lobularity, radiomic features, enhancement, texture, cluster analysis. And then there are additional layers that we can look at and add to the picture of what to do with these small renal masses. So can we quantify shape? They thought that, as perspectiveless, shape is very subjective and is susceptible to intra and intra observer variability. But they're doing contrast-enhanced ultrasound. Prior to this, I didn't know much about contrast-enhanced ultrasound, but it has a role. So you can assess vascularity, and it may help in surveillance as well as guidance for biopsy. Because let's think about it. Clear cell carcinoma, VHL, which chromosome? 3, exactly. And so what's one of the endpoints of VHL disruption? Right, so you can have, ultimately, a change in angiogenesis. So with something like contrast enhanced ultrasound, you can look at a mass and you can tell whether or not it's more vascular or less over time. So here you have a case, a patient with a Bosniak 3 cyst, and looking at it with regular ultrasound, you can't really tell very much. But here, with contrast enhanced ultrasound, you get a little more information. This patient had a partial nephrectomy and it was clear cell. So, sorry, it's a little difficult to read this. It didn't copy very well, but there are some imaging findings and contrast enhanced ultrasound findings associated with each tumor. So you can also follow neoangiogenesis over time. And so grayscale shows the mass, and then here you have contrast enhanced ultrasound. So that's imaging, and sort of some theories that were put forward about imaging. Now, biopsy. So here, you have a person, guy, abnormal DRE, and a PSA. You can biopsy them. This is the whole mount. There was tumor here. So can we do the same thing with the kidney? Not necessarily. 2.7 centimeter renal mass here. So histology, clear cell papillary, 1, 2 chromophore oncocytoma, and various severe grades. Here, looking at outcomes of the various subtypes of kidney versus prostate. So it would be great if we could somehow, as we use the Gleason score to predict behavior, if there was something that we could use to predict the behavior of small renal masses. So we do biopsies. So here, looking at some of the biopsy data, the diagnostic rate, and the complication rate. Again, the complication rate is very low. Major 5%, major 0.02%, minor 5%. And stratifying care. You can do a biopsy. If it's benign, you can follow up. If there was a way to determine favorable, intermediate versus unfavorable, we can stratify patients to active surveillance or surgery, or if it's indeterminate, we could repeat the biopsy. So again, here, just another way that they're doing biopsies and using biopsies to direct closer, more group biopsies of the kidney. Similar to what we're doing with MR fusion biopsies of prostate. So, just kind of looking at what they're doing for small renal masses at their institution. So, biomarkers. So again, biomarkers, we're using them for other tumors. We have PSAs of multiple prostate. We have the testicular tumor markers, which we use to assess risk in testicular cancer. So, can we do that with the kidney? So, here you go. 64-year-old male, microhematuria, lesion here. Those are his comorbidities, 2.8 centimeter left lower pole enhancing mass. He got a robotic partial nephrectomy. Don't answer, but just think. What do you think the pathology showed? Here's someone else, 50-year-old female, back pain workup, lower pole renal mass on the right, smoking history, 3.4 centimeters, robotic partial nephrectomy. So current challenge, we don't have a PSA for small renal masses. So, there are some reports in the literature about urine or serum markers, but they're not really great. Again, people are trying, but there's not enough data yet. We're just not there yet. So, recommendations from the guidelines, currently the AUA recommends against the use of routine markers because the benefits remain unproven at this time. And the European Association of Urology agrees and feels the same thing. So again, this is a work in progress. We're just not there yet. So, case 1, enhancing lower pole on the left. This turned out to be an oncocytoma, probably someone we could have watched. Case 2 turned out to be a patient with clear cell and renal cell carcinoma. And today's markers do not meet the challenge, not right now. So again, omics, proteomics, biomarker development. It's what we need to further characterize these kidney lesions. So AUA guidelines, active surveillance, clinically localized RCC, biopsy has a role, imaging has a role. Hopefully this is what will happen in the future. We'll have renal mass, you'll be able to biopsy it, do some molecular profiling, and determine which 20% are benign, which 60% are represent indolent RCC, and which 20% are aggressive and require surgical incision. This is what we hope in the future. Guidelines, again, current guidelines for the management of T1A, T1B lesions available online. And that's it. I have, I'll take some questions, and I have a couple of videos if you'd like. I know it's been a long day. You guys have been sitting in those seats for a long time, so. Any questions?
For some reason, you know that the collecting duct renal carcinoma and the medullary renal cell carcinoma arise from the same cell origin, okay? And usually arise from the central portion of the kidney, very near and very close to the collecting system and the venous system, with potential very rare invasion, vascular invasion, and they are, as you know, very recent tumors. Still, can you consider them two separate entities, the collecting duct renal carcinoma and the medullary renal cell carcinoma, which arises in the patient with sickle cell trait? This is the first question. I have another question.
Do I know which arises from where?
Both arise from the collecting duct.
Right.
Do you still consider them two separate entities? The collecting duct renal cell carcinoma, the collecting duct renal cell carcinoma, and the medullary renal cell carcinoma.
I consider them, I think of them as two, because not all patients have sickle cell trait, but I manage them the same.
The only way of discrimination is the presence of sickle cell trait.
Yeah, that, to me, that's the way that I, sort of look at it and view it, but I manage them both.
Those are near physiologically are similar, more or less similar. And they are very aggressive and very aggressive humans.
Yeah.
Okay?
Yeah, they're very
Still,
aggressive.
the only difference is the presence of sickle cell trait.
That I'm aware of, yes.
This is my first question. My second question is the rule. You know actually the renal tumor is radiological diagnosis, unlike bladder cancer, which is histopathological diagnosis. What is the rule of finding aspiration biopsy in patients with suspected renal cancer?
So FNA, some people, thought about FNA before, but I don't think that FNA has a role in as much with the diagnosis of renal cell carcinoma.
You have a third and absolute indication for not finding need of aspiration biopsy in patients with renal cell carcinoma. Or still, you depend, as we know, all of us, renal neoplasm is a radiological diagnosis. Third and absolute indication, if you suspect, for example, these mass may be inflammatory, these mass site of origin may be the kidney or the prerenal gland, or in small renal masses like you said.
Right.
Do you think you have a rule for finding aspiration process in these cases?
So with FNA, still no. So say for instance if there's a patient who may have a kidney mass or an adrenal mass and I'm not sure, if I'm concerned about an adrenal mass, I will do functional studies before sticking a needle in, because if I'm dealing with a field or something like that and I biopsy it unwillingly, not knowing what it is, I can precipitate some sort of crisis. So if I have a thought that it's an adrenal mass, I will do, urine metanephritis and that sort of thing to rule out a field first. In terms of other indications for a biopsy of a renal mass, say if it's a patient that's older, a few comorbidities, and they're not sure, they're on the fence about what they'd like to do, then I would do biopsy for sure in that setting, just to sort of get an additional bit of information to help them make their decision. Also, if there's someone who has cancer somewhere else in their body and a mass in the kidney, I'm not sure if that's a kidney mass or if that's a met somewhere else, I'll do biopsies in that setting to determine whether or not I'm dealing with a renal primary or a met or something. Those are some of the, sort of absolute reasons why I would do a biopsy. The other reasons, I think it's a big gray.
Thank you.
Proceed with the video.
Okay. Great. I'll hand the mic to you so you can ask the question, and I'll set up the video.
Okay. I'm asking about the follow-up of small renal masses. The guidelines for follow-up of small renal masses, timing of biopsies, follow-up biopsies, timing for follow-up CT with IV contrast. I understand the measures to follow up small renal masses, but I can't put them in the algorithm, or I can't put them in the follow-up regimen like bladder masses.
Okay.
When to do
Here, I'll bring that up. So there's sort of a flow diagram that I'll share with you. I just got to find it. So the videos that I have to show are some of the best of AUA videos for partial nephrectomy and robotic partial nephrectomy. So one thing, because we're now doing focal therapy for some kidney tumors, what happens when these focal therapies fail? What if you have a suspected recurrence in a site that was previously ablated using cryoablation? Well, one of the best videos that I saw and reviewed came out of New York. I think looked at. Do we have the sound? Aspect of the upper pole of the left kidney, the previous site of cryotherapy. A 9-year-old male who in 2011 had a cryoablation of a left upper pole renal mass in conjunction with a laparoscopic bowel resection. Follow-up MRI in 2015 demonstrated a bilobar mass in the posteromedial aspect of the upper pole of the left kidney, the previous site of cryotherapy. As you can see in this imaging series, the lesion demonstrated both a non-enhancing exophytic component as well as an enhancing endophytic portion suspicious for renal cell carcinoma. On this coronal view, both the exophytic and endophytic components can be appreciated. We pick up the operation with identification of the ureter, the proximal dissection of which facilitated identification of the renal hilum. Because of the posteromedial location of the tumor, full mobilization of the kidney was undertaken. The dissection was difficult along the lateral sidewall, as you can see here, and against the spleen, secondary to the desmoplastic tissues encountered around the previous cryotherapies. Here you can see the circumferentially cleaned off kidney along with the cortical lesion, which required the surgeons to flip the kidney in an inferomedial fashion. On ultrasound, the exophytic lesion that had previously been ablated demonstrated empty echogenicity, and the endophytic lesion was not visualized. Once the probe was placed at a tangent, however, the intraparenchymal lesion was readily apparent at 2 angles and demonstrated vascularity. In this case, the renal hilum was not skeletonized, and components of adipose tissue were entirely
intentionally left as a buffer between the clamp and the vessels. This was primarily done to protect the vessels as the patient previously had a complete hilar dissection during his previous cryoablation. Resection of the tumor was undertaken around the previously scored outline. Deeper in the resection, a pseudocapsule was identified, and the renal tissue was delicately peeled off the defined tumor capsule. A similar technique was utilized in separating the collecting system from the tumor. And ultimately, the lesion was cleanly dissected off of the healthy renal parenchyma, as demonstrated here. At this point, 4 quadrant biopsies of the tumor bed were taken and sent for frozen section to ensure negative margins for this unique resection. The frozen pathology results all returned negative. The collecting system was addressed using a stratific suture with lacquer ties. After which, the renal cortical defect was addressed using the standard sliding clip or Norfie technique. The final reconstruction with hemostasis and removal of hilar control is seen here. And at the end of the case, the kidney was pexed to the sidewall. The pathology specimen is elegantly showcased here, with well-demarcated margins separating the exophytic ablated lesion, which was located on the top, with the residual developing renal cell carcinoma, which was located on the bottom. The postoperative course was uneventful, with an operative time of 152 minutes and an ischemia time of 27 minutes. The estimated blood loss was 50 cc's with a postoperative creatinine of 1.1. The length of stay was 2 days, the most recent creatinine is 1, and final pathology demonstrated clear cell renal cell carcinoma. Thank you very much for watching our video.
What this shows us is that the robotic surgeons are getting better and better at what they do. Because I would not imagine the day before where we would have been able to go back after cryoablation into the robotic part. So it's just about 4:30 now. I guess another video. Okay. So.
At the Cleveland Clinic, we have performed more than 1,100 robotic partial nephrectomies over the last 9 years, of which approximately 9% were from hilar tumors. Despite the increased size and greater complexity of hilar tumors, in our hands, RPN generally achieves satisfactory surgical outcomes with low blood loss and acceptable warm ischemia. Our complication rate for hilar tumors is 31%, 10% higher than on average, but most complications are minor. In this video, we intend to highlight the challenges of RPN for hilar tumors and to demonstrate techniques that facilitate its safe and effective execution. The principal challenges are twofold: to perform a complete margin-negative resection without injuring the renal hilum, and to provide a hemostatic closure without sacrificing renal perfusion. Herein, we present 2 exemplary cases. The first case is a 36-year-old man who was diagnosed incidentally with a partially amphibic clinical T1B right renal mass involving the hilum, nephrometry score 11. The second case is a 73-year-old man with a 4.6 centimeter entirely endophytic right renal mass invading the central sinus vent. Tumor excision, case 1. After fully mobilizing and defatting the kidney, we are ready to proceed with tumor excision. The mass is identified on ultrasound and the borders of excision are marked. A partially exophytic tumor is seen just anterior to the hilum. The hilum, which has already been dissected out, is clamped prior to proceeding. The artery feeding the tumor is ligated and divided. Using a hilar approach, a plane between the mass and the vessels is defined. The mass is undermined and dissected off the vessels in an antegrade fashion. After the mass is safely off the hilum, dissection is allowed to catch up on either side of the mass. Segmental vessels are controlled as they are encountered. Once the mass is completely excised, it is set aside for later extraction. Case 2, tumor excision. As in case 1, the kidney has already been fully mobilized, defatted, and the hilum dissected out. Due to its completely endophytic nature, the tumor is not visible on gross inspection. Based on pre-op imaging, the mass is known to reside anterior to the hilum. Ultrasound is used to aid identification and define the borders of excision. Prior to clamping, an attempt is made to define a plane between the tumor and the hilum. If dissection fails to progress or bleeding is encountered, as in this case, the hilum is clamped and dissection proceeds distally. In this case, the parenchyma is incised around the tumor, but the tumor is not easily identifiable. Dissection is carried out on either side of the tumor, defining its lateral boundaries. After reflecting the overlying normal parenchyma, the tumor is identified deep in the center of the kidney. The tumor is circumferentially dissected free from the normal parenchyma, excised, and set aside for later extraction. V-hilar suture renorrhea, case 1. Following excision, a large central defect is present over the hilum. Closing this defect in the usual two-layer fashion would either leave a gap or would put the closure under excessive tension, threatening renal perfusion. The V-hilar suture technique, as described by our group, provides a tension-free hemostatic closure while maintaining tissue perfusion. In order to perform this technique, the deep layer is first closed with two 2-micro sutures running from either side towards the hilum in the outline of the V. In a similar fashion, the capsular closure is performed with ovical suture in a running horizontal mattress fashion, with each throw secured with a sliding foot. After early unclamping, additional capsular sutures are placed. The final result is a tension-free hemostatic closure, which resembles the shape of a V. Clamshell renorrhea, case 2. In case 2, tumor excision left a large clamshell defect, in which only a small isthmus of hilar tissue remained connecting the upper and lower poles. For this situation, the V-hilar suture technique, or standard renorrhea, is not feasible. Instead, the kidney was repaired in multiple deep and superficial layers. From an anterior approach, the deep layers are first reapproximated in a running fashion with 2-micro suture. The kidney is then rotated, and the posterior capsular closure is performed with ovical suture in the usual fashion. The kidney is rotated back to its anatomic position, and the first layer of the anterior capsular closure is performed. After early unclamping, a final cortical closure is performed. enormous clinical impact. Pathology showed T1B clear cell RCC marked negative. 3-month creatinine was 0.9 and GFR preservation was 77%. Case 2. The operative and normal scanning times were increased, but surgical outcomes were good. Pathology revealed that T3A clear cell RCC was fading into the sinus battle, ranking the mark as negative. Short-term functional outcomes of the solitary camera were remarkably good. In summary, for precision, we developed a link between the tumor and islet, undermining the tumor and rolling it off the vessels. For a northeast, the V-power suture and clamshell multilayer closure techniques are highly effective. In conclusion, RPN is technically feasible for highly complex, highly tumors and avoids nephrectomy or large incision. Operative time and enormous ischemia may be prolonged, but intracorporeal tooling, early implanting, and selective clamping may be useful. For select cases, clinical, mycological, and functional outcomes are excellent.